Welcome to the Basic Life Support Targeted Probe and Educate webinar. I'm Tom Ryan with Provider Outreach Education. I'll be one of your presenters today. I'm joined by Mary Sue Gardner. She's also from Provider Outreach Education, but she is one of the clinical presenters, and she'll present after I do. This presentation is available for download on the Live Events page. The address will be placed in the chat. You can go ahead and grab it if you want it. It's not something that's required, but it just might help you keep track of where we're at. I want to let you know that if you do have questions, please put them in the chat. What we will do is handle all questions a couple of different points throughout the presentation just to make it a bit easier. Last, please make sure that you review the presentation. The disclaimers are at the end, and everything in this presentation is current as of today. But because Medicare does change, different things can happen. So make sure you're reviewing the CMS website, the rules and regulations. Those will always prevail over educational material like today's presentation. The big question of the day is, what are we here for? We are really here to look at the ambulance suppliers building basic life support and what will happen with the targeted probe and educate reviews that are starting in jurisdiction 8. Now, this doesn't mean the information isn't relevant to everyone, but these are based on the targeted probe and educate, which is a selection of reviews. So we do want to define the BLS transport. Then we do want to define more about the targeted probe and educate system and what it's about. And then we're going to talk about medical review, like what documentation are they looking for, what should be there, what should not be there, all of those types of things. So we want to make sure you're well aware of it. I do want to remind everyone that information given during this presentation does not apply to Medicare Advantage plans. It is designed around Medicare fee-for-service, which is Part A and Part B, targeted probe and educate. It is also designed around Jurisdiction 5 and Jurisdiction 8. That's Iowa, Kansas, Missouri, Nebraska, and Indiana, and Michigan, and our national providers. It is not designed around any other jurisdiction. So while you're welcome to attend, this may not be applicable to you. All right. Reminder that if you are looking for an acronym such as BLS, TPE, something like that, check the notes section of the slides. Sometimes we throw that down there just to help you out, but we want to make sure you're well aware of it. First, I do want to talk about the BLS Transport Criteria. These criteria are what Medicare is looking at to determine payment. In other words, we have to check for certain things. And those things are based in the federal law, and that's what we're going to talk about so that you understand the criteria and you understand what medical review is looking for. Then we're going to turn it over to Mary Sue, and she's going to talk about the documentation for that criteria to make sure that you have everything in place. So the first thing that Medicare does have to look for is some basic things, and Mary Sue will talk about that documentation, such as signatures, dates, that type of thing. But in terms of the criteria, the very first item is that the service is not contraindicated. In other words, under the Social Security Act, Section 1861S7, a patient's transport must be the only safe means to get them to a medical service or a destination. Without that said, without that being met, the transport will not be covered and is not then billable as a medical necessity transport to Medicare. This means that you will include a GY modifier if you do need to bill it. So we want to make sure you're well aware of that. So if we know it has to be medically necessary based on this, and we also know it has to be a transport because the law says so, so that means a treat no transport would not be billable. Just keeping that one in mind as well. Let's talk a little bit about medical necessity. It establishes the patient's need for the level of transport. So it's not just about, hey, do we need to transport them? Is it the only safe means to get them there? It also says, do they need to go by ground versus air? Would BLS suffice versus ALS? Would ALS 1 suffice versus ALS 2? These are all part of establishing what medical necessity level that the patient needs to go at. So we have to consider also the Social Security Act, Section 1862A1A. So that's two different sections. One says It has to be medically necessary in general. That's Social Security Act 1861 S7. That means that this is the only safe means of transport. Any transport must occur. The other one says, hey, along with being medically necessary, it has to be done at that level of care, which is 1862A1A. Okay? So when we look at that, those are some of the really basic things we're looking for within the documentation. How are you determining that? When we also look at it, we're like, wait, what else needs to be in there? Well, there are times when if it is performed at a higher level than is necessary, for instance, the patient went by air but ground would suffice, that's when an advanced beneficiary notice of non-coverage would be needed for documentation. Now, typically in a BLS service, you would bill that with a GA. Now, why that? Does anyone know? That indicates that it was performed at a higher level than is medically necessary. So it is medically necessary. It is something that meets all those conditions, but it was billed at a higher level. And that's when you would bill for that service, but you would indicate that you did give an ABN, Advanced Beneficiary Notice of Non-Coverage. Okay? There are a couple of considerations. One, do you need to do an assessment? And the answer is yes, because Medicare Part B never considers a round trip. Each trip is considered separately. What does that mean? Medicare Part B is a benefit category. Medicare Part A is a benefit category. Those are the two types. Part A is an inpatient benefit category, and when the patient is inpatient, there are separate things that apply that would also then exclude BLS services because they bundle into that inpatient care. That's when a round trip can be considered, only when the patient is inpatient and Part A is paying. When you hit a Part B trip, which is again a different benefit category, then there is no round trip, so therefore an assessment must occur. Someone said to me, I have a ER transport. So we transport to the ER, then later we go back, we pick them up, and we transport back. Each one must have an assessment, separate and identifiable. Okay. The first one, you're going to have less information. You might, depending on where you pick them up at, have something from like a skilled nursing facility. The second one, you would still have that same information, but you would also then have an ER report. Now, just because a transport to the ER is medically necessary, the transport back is not always medically necessary. And that's something that will be proved in the documentation that Mary Sue is going to talk about. That's why we put that in here, because there's a misconception that when you took them, it automatically means the transport back is medically necessary, and that is not true. One thing when you're looking at what you know, what does that EMT know? How are they treating the patient? One, they have to know that it's going on. They have to understand what's happening. So they do always have a dispatch reason. That isn't necessarily what they find when they get on scene. How many of you guys have been an EMT or had an EMT who showed up and they were dispatched to a possible heart attack, but they get on scene and the person's up walking around with pack bags and needs to go, and you're like, what? That was completely not the reason. Or they say, oh, I have to have this going on, but you get there and that's not what's going on. That's why we do want to make sure we know what's on scene. Also, what bystander information do you know? Now, this sounds very interesting to people, and we do always recommend that you incorporate this into your assessment. Mary Sue will talk more about this. But did a bystander tell you that you found that that the person was found lying on the street, but nobody has any idea what's going on? Were they found walking down the street, simply fell over and passed out? Were they hit by a car and now they're laying there complaining? That's all stuff that may come from a bystander, depending on what you're finding. And so you really want to be able to put that information in there. Please don't discount information coming from a family member, such as heredity, past medical conditions, other things like that. Mental health bystander information is important as well. Okay. Someone asked us about hospital reports, so I wanted to just take a moment to talk about that. First, a hospital report is not considered if it's not known. So you are transporting from a patient's home to the hospital ER emergency room. that hospital discharge report coming from the emergency room was not known at the time of transport. As a matter of fact, it didn't even exist because the patient hadn't been seen yet. That's not something Medicare can consider when looking at documentation. However, if you're picking them up at a hospital and you're transporting them for higher level of care or for something that doesn't exist at that hospital. For instance, you're picking up a burn patient at an ER, they're stable, they're ready to go, but now they need a burn unit. You do have a hospital report, usually a discharge summary from either the ER or whatever the stabilization was, and that can be considered as long as the EMT has it in advance and is well aware of it. Now, it could also be something that they share via summary from the nurse or from the treating personnel to the EMT. That's okay as well. It's how did you get it and help us understand that. So we'll talk more about that. Physician certification statement. This is a statement that is required sometimes and other times is optional, but it comes from a physician saying this is why we need you to transport the patient. It does not override the assessment. Did y'all catch that? It does not override the assessment. It should help the EMT to understand the assessment. So that's why a physician certification statement, according to CMS, alone does not make a service medically necessary and it's payable. The assessment is what does that, and Mary Sue will talk more about that. Last, of course, you're going to want to consider whether or not they're inpatient because that falls under inpatient bundling, whether that's in a skilled nursing facility or hospital. So lots to consider when you're looking at that. And we'll talk more kind of about that as we get into some of those documentations. Some things that we don't really want to consider, again, if it wasn't known at the time of transport, then why would you consider it when you're picking your level of service? The reason that we don't want to consider it is because the EMT wasn't able to act upon it. They weren't able to do an assessment based on that. One of the things that we do get in is a physician's note or an office visit note. Well, that's great if you're doing a physician certification statement, but if you're not, did the EMT know that at the time of transport? I can't answer that. Another item we tend to get in, diagnostic and lab services. Again, did the EMT have that information at the time of service? Did they document that they had it? Mary Sue will talk more about that. So really when we're looking at things that we don't consider, it's things that happen after the fact, things the EMT did not know at the time of service or have no indication that they know at the time of service. Okay. What's another criteria that must be met? It has to be a covered destination. Medicare does not pay for you to take them anywhere that they want to go. We have had claims submitted and we're like, what? Why is that patient going there? That just doesn't make sense. Now, how do we know that? The documentation is pulled and then in the documentation, it states where the patient wanted to go. So that could be a home, that could be a variety of other things, okay? So please make sure that you're using the appropriate destinations. I do want to point out that there is something called a P and an X. And you'll notice these are both physicians' offices. P is not a covered destination. X is a covered destination, but X is not a valid origin. P is a valid origin. So you picked them up at the physician's office because they needed to go to the ER. Perfectly fine. P to H. Now, you pick them up at the site of an injury. Okay, so that makes sense. This is the scene of an accident or acute event, S, and you stopped at a physician's office for stabilization because they were not going to make it to the hospital. That is an X. That's what it is. It is not a P. Then, okay, they're stable. The physician gets done with them. Now they're going to pick them up and continue on to the hospital. Then you have the second, which is a P to an H. And yes, they both are payable transports. Yes, they both are payable mileage, but you do need to indicate why you stopped, what was going on, and why that X is an applicable destination. So we really are looking at all of these different weird mileage coded and item things like that. Now I just said mileage, so let's talk just briefly about that. First, when we look at mileage, we do start with what is the nearest appropriate facility. The nearest appropriate facility is the facility that has the staff and equipment to treat the patient and is physically nearest to that patient. We'll then use that facility and run a data analysis to see if it falls within the same locality. The data analysis is a data formula that's done, and it does give us some different areas and hospitals you can go to. So when we look at a facility, it has to have the staff and equipment available to treat the patient. If it doesn't, you need to indicate that. For instance, why did you bypass this critical access hospital? Well, maybe that critical access hospital does tell us that they can treat a cardiology patient, except what it doesn't tell us is that they only have staff available to treat a cardiology patient on Tuesdays, because that's when certain types of surgeries are done, or maybe that's when they have that. Well, we don't know all of that. None of the directories give us that information. So that's where you might need to put that in. Someone asked about transport to a patient's home. And yes, Medicare does recognize that. It is a mileage restriction. We probably are not going to pay for them to be transported 300 miles, just FYI. The question that came up with this one in particular was really, is it their home or is it a relative's home? And Medicare doesn't say that. They do use R for residence, and it is a private residence. This could be a house or an apartment, something like that. Okay. And then again, I did note on here that emergency stop only for a physician's office. Again, the X destination, the P is the origin. So when we look at that, that builds our basics. What does that mean? This gives us what must be documented in order to make it payable. This meets the two sections of the Social Security Act. So I'd like to take a second, show you a couple things on the website, and I'm going to give it to Mary Sue to see if we have questions, and then she'll actually start presenting. So let me just go ahead and end this PowerPoint presentation and go to the website. All right, so here's our website. First, when you're looking at all of the information on our website, you want to go to the Topic Center, and you're going to go to a variety of pieces of information. Documentation is what Mary Sue's going to cover, but let me show you that article. If you go to documentation and you scroll down for just a second, you're going to see a lot of documentation guidelines. This header called documentation, you open it up, you'll see ambulance. It's the fourth article down. Now you could say I went to specialty ambulance or A to Z. It's all the same article. It's just a different way of getting there. This will walk you through all of the ambulance documentation information. Lots of stuff out there. It's going to refer you to different sections of the Internet-only manual, the Medicare Benefit Policy Manual, the Medicare Claims Processing Manual, all of those different things, and you can simply click on any of those and they will open up. These are links that are provided to you. One thing, as Mary Sue talks about documentation, don't forget that there's also claims information that needs to be coded, and that's going to be just in a little bit of a separate article. Again, you're going to go to claims here, and you're going to scroll down, and you'll see claim submission, and then ambulance billing. Now this article just goes through some of the different pieces of information that we found. It is not the same as what is in the claims processing manual, which is again part of those internet-only manuals with their day-to-day operating instructions, and is linked. So there's two resources. There is another one, and this one is designed really just for some general information, but it's under benefits and eligibility. It's the information I just went through. So under benefits and eligibility, the very first thing that opens is ambulance, and it walks you through the ambulance information you need. Okay. Really, again, designed to be super general, high-level information, but it really is the basis for these targeted probe and educate reviews. Mary Sue will talk more about that. The last line you need to be aware of is going to be in jurisdiction 8, okay, and it's going to be in line of business part A and line of business part B. When we go to that, I'm in part B right now, so we'll say where we're at. We're going to go to medical review, and under medical review, if you scroll down, you will see a header called targeted probe and educate. So here it is. Here's where you're going to find out more about the basic life support review that is going on. This is what I'm going to give it to Mary Sue to cover. I'm not going to try to cover all the documentation ins and outs and things like that. So she'll talk more about that. That was the basic question that I had submitted and covered some of those different resources. We checked with Mary Sue very quickly to see if we had anything coming in chat while she also gets set up to go ahead and start her presentation and going on. So Mary Sue, did we have anything in the chat?
Hi, Tom. There are no additional questions in the chat.
Well, perfect. Then you're up to start sharing. Go ahead and go forward.
All right. So just as with Tom, you're going to see a few little gray boxes moving around. That's completely normal as I just ready my screen. And give me just one more second, one more little gray box to move. And we should be good to go. I'm going to ask Tom to verify that he can see my PowerPoint. And everything sounds good on his end.
I can see the targeted probe and educate slide, and we are ready because you sound great.
Perfect. Thank you, Tom. Well, I'm going to start the second half of this presentation discussing the TPE process, otherwise known as targeted probe and educate. So TPE is a review process where we, as your MAC, we identify providers or suppliers that have a high probability to perform errors in specific services, namely ambulance in this case. So the goal of the TPE process is to help providers and suppliers reduce claim denials and reduce appeals and provide one-to-one help to these providers. We identify providers that pose the most risk in the service that's going to be reviewed. We then review a sample of their claims. And that's generally 20 to 40 claims. We identify any errors, and then we help you actually correct those through an education process. So as a provider, you could be subject to up to 3 rounds of review. Each provider is assigned to a nurse reviewer. And that nurse reviewer actually provides personalized one-to-one education to help you fix those errors and reduce denials and improve billing accuracy. So since it is very targeted, since it is driven at providers who have the highest potential to perform issues, that means most of our providers will never be subject to a targeted probe and educate review. So that's good news on your end. But if we do happen to pick you, we want to make sure that you are ready and that you have all the information to, successfully pass a review or an audit or an edit. We're going to start with what kind of TPE reviews are going on at WPS. Now, Tom showed you the medical review site and where to find this type of information. We're going to start with a TPE review that's currently going on in J8 Part B. So this problem is new for this year. We're looking at HCPCS code A0248, and that's basic life support non-emergent transport. Now, we identified this problem due to a July 2025 CERT report where it showed about 25% error for ambulance providers. So if the CERT contractor is looking at something and they're identifying errors, we don't want our providers to have errors. And that's why you'll hear us refer to, CERT or CERT findings. If they're finding an error, that error is assessed on us as your MAC. We don't want to have that error. We want to have providers that have no errors because, again, just like if you get audited, you don't want to have an error rate, or you want to have the lowest possible error rate, that can be found. So that's why If CERT's looking at something, we jump on the bandwagon and we look at it too. We try to get to our providers before the CERT contractor might get to them. And we want to educate you and let you know what the CERT the CERT contractor is finding and help you avoid these issues. So clinical reviews will verify actually the level of ambulance service billed, along with a validation that the transport by other means was contraindicated. So they're looking for medically necessary services. That's the contraindicated part. And they're looking to make sure it was billed appropriately, and in this case for BLS service. So we did data analysis, and data analysis was performed, and we identified 31 providers in J8 Part B. That's Indiana and Michigan. And those providers were billing above the targeted threshold of 339.41 units per provider. And that was the average. So issues identified from this problem include inadequate physician certification statements. Tom's talked about that. I'm going to talk about that. We're going to hopefully look at an example of that as well. Missing assignment of benefits, or AOB. So we're going to pursue these 31 providers. We're going to start targeted probe and educate reviews. Those are going to start in April, May, and June of this year. So hopefully none of you are picked, but if you are, know that probably starting in February, March, and April, you're going to start getting letters, phone calls, letting you know that, hey, we're going to start a review of your services. All right, moving along. This is another BLS review that's going on in J8, again, Indiana and Michigan. But the focus on this one is on our Part A providers or suppliers, so facility-based. The HCPCS code identified under this review is the A0429, so that's the BLS Emergent transport. So this problem carries over from last year and is actually, it actually originated several years ago. When this problem was originally identified, we found that J8 Part A providers, that those identified had an average of 339.75 units per provider. So that's just for the BLS Emergent transport. The national average per provider for the BLS transport is 196.24. The CERT contractor also looked at the issue, and they found an error rate, and they found that that error rate actually, through their reviews, increased from 7.8% in November of 2021 to 25% in July of 2025. Obviously, with that increase in error rate, that's why we jumped on board. We looked and did data analysis. We identified providers. In our updated analysis, we found 15 providers that were actually reviewing above that targeted threshold that posed the greatest risk. So we started reviewing them. So clinical reviews, again on this one, are going to verify the level of ambulance service billed along with a validation to support medical necessity. Again, meaning it's contraindicated by any other means. From the reviews that have already happened and the prior CERT reviews, the most common identified errors of this problem are that the documentation submitted did not include that AOB, or that assignment of benefit form. Also, the documentation did not support that the care was provided by people or persons that were trained EMTs. So if you just say technician, we don't know what level of training they have. You need to make sure you are documenting and that your EMTs are actually signing with their credentialing. Is it an EMTB? Is it, you know, higher? Is it paramedic, etc.? All right, the next review going on in J5. This one's actually an ALS claim review, and I know the basis of this webinar is BLS, but I want you to be aware that we're also reviewing ALS services. So this also is a carryover issue that continues into this year. When the analysis was first conducted, they were looking at the HCPCS range from A0426 to A0429. And they found that the A0427, which is the ALS Emergent Transport Level 1, that was actually disproportionately billed compared to the national proportions. There was cert reviews for this that were done as well. And that, again, prompted the reason why we continued on and started with reviews. The data analysis for this issue actually identified 107 providers that were above the targeted threshold of 48% proportion of units of the A0427. And that was, again, within that A0426 to 429 range. And 133.89 units per provider. That's the national average. So they were above, these 107 were above that national average. So the clinical reviews, again, verify the level of service along with medical necessity. Some of the identified causes of issue include missing the beneficiary signature or his or her representative for the purpose of accepting that Medicare assignment, that AOB. Transportation was not to the closest appropriate facility. Remember, Tom talked about if you're not going to the closest appropriate, if you have to bypass it, why was it bypassed? We're going to talk about that in documentation as well. Transport by other means was not contraindicated, and documentation does not support the miles billed. So if the run sheet for the loaded miles and the miles billed on the actual claim do not match, there's going to be a denial probably of services. So let's move on and talk about the fun part. Well, fun part for me anyways, the documentation. There are some specific components of documentation that need to be submitted upon review. The first of these being the trip record. The trip record generally consists of almost all the pieces of documentation that need to be submitted for a review. So this includes why you were dispatched and how you were dispatched and the point of pickup and the point of drop-off. If you don't have an address, then you can provide something like the closest intersection or mile marker where you picked up that patient. How many loaded miles? Remember, ambulance services is a transportation benefit. So we're paying based on the transportation. We don't want you to include the miles to the point of pickup with your billing. Only the loaded miles are billable. So that's what we need to focus on. Yes, you can document all of your miles, but we need to make sure that what you billed and what you transported, that those miles actually are the same. Next, what service did you provide or services did you provide? This is where you're supporting the level of service that you're providing. So here's where you actually support medical necessity. That is, you know, again, medical necessity is transport by any other means would be contraindicated. So tell us, is there bed confinement, unconsciousness? If it's a medical emergency, document to that medical emergency. You really should be detailing that patient's condition. Now, Tom always says, use your senses and describe what you sense. So what do you see? Is there protruding bones? Is there a bluish color to the face? Are there chemical burns, etc.? What do you hear? Are there decreased breath sounds or rales in the lungs? The patient's crying in pain, irregular heart rhythms, no audible blood pressure. What do you smell? Does the patient have fruity breath, which may be diabetic ketoacidosis? Do you smell gangrene or infection? Any of us that have been in the medical field for long enough know what that smells like. Does the breath smell fecal, like poop? That could indicate bowel obstructions or perforations even. Are there's like specific chemicals that you could smell? Do you smell fuel? Do you smell something that smells like cat pee? That could be methamphetamines. Methamphetamines, unfortunately, smells like cat pee. I know that because my husband's a law enforcement officer, not because I know anything about, people that make meth. But I do know that making a meth smells like cat pee. What do you feel? Are there irregular pulses? Is there a sucking chest wound? Do you feel irregularities of the bone structures? Finally, taste. I don't recommend that you taste anything. However, we all know that there are some smells that can elicit a taste. Document those by smell and just leave the taste out of it. So anyways, finishing up on this slide, and then we'll continue on to the next. We also need information documented on the closest appropriate facility. So the closest appropriate facility is the one that's in that radius and is equipped and able to handle that patient's medical needs. If you're going past a facility or bypassing a facility, we need to know why. Are they closed to trauma? Do they not have bed availability? Is their CT scanner down, etc.? Are they not equipped to handle a trauma case? Finally, on this slide is, again, the assignment of benefits, and we've talked about this a lot. Remember, for Medicare ambulance services, the BENI or representative must sign an AOB form agreeing to let you as the ambulance provider or supplier bill Medicare directly and accept the Medicare approved amount as full payment. And that's minus coinsurance and deductibles. If the BENI can't sign, a legal guardian can, a representative of the payee can, a relative, a caregiver arranging for care, or an institutional rep. But as an ambulance crew, you must document why the beneficiary couldn't sign if they can't. Are they under distress in an emergency? Then you can get a signature after the fact if that's, one thing that you have to do. So as we move on in documentation, some additional components. Tom talked about the advanced beneficiary notice of non-coverage. If one was issued, you need to submit that in your documentation. In the event that there's missing or illegible signatures, you may need to provide a signature attestation statement for that crew. And then finally, a physician certification statement if it was necessary for the transport. Tom had mentioned this too. Certain transports, like repetitive scheduled non-emergent ambulance transports, require a physician certification statement. Now, we have a sample physician certification statement on our website, and I'm going to link out and show you really quick, and I'm going to actually copy where I'm going to and put it in the chat as well. But let me link out there and show you our website. And I'm just going to choose J5B. So under the forms section of our website, and you can find forms under tools, all tools, and scroll down to all forms. And then you can find Oops, did I go right by it? Maybe it's not on this page. Signature attestation statements are on there. Oh, here we go. Physician certification for PCS. So that's one way to find it if you lose that link that I sent you. I'm going to go to download, which is going to open this form for us. Now, if you are a ambulance provider supplier that performs something like non-emergent ambulance transports that require a physician certification statement, I highly encourage you to go out and look at this sample form that we've created and posted on our website. It is not a requirement that you use it. However, I strongly encourage you to go out and take a look at it. You can download it and use it. We've developed this as a means to make sure that you are really supporting the medical necessity component of your transport in these cases that require physician certification statements. We've thought about all the different kinds of things that may make a transport medically necessary and included that information into the questionnaire section of our sample form. Again, you don't have to use this. We don't require you to use this, but I do encourage you to go out and take a look and to maybe consider, if you have one that you have, does it have all these different types of components to it? Is there something you can update to make yours better? And if you think, well, maybe ours isn't all that great and we're going to ditch that and use this one, then that's great too. So again, if there's special considerations for the patient because they can't sit or they're unable to hold themselves up, is there any kind of special anatomical positioning that needs to be done? Are there special handlings? Are there things that the physician wants you to do for the patient during transport? Do they need to be restrained? Are they seizure prone and you have to monitor something? Are they vent dependent and you have to make sure that you have them on the correct settings, you're administering any medications, etc.? Do they need to be on continuous ECG monitoring during the transport? These are all things to consider that really help support the medical necessity of your service. Now I'm going to go back to the slide deck. Hopefully here. There we go. And we're going to move on. And I just want to talk about RSNAT services for just a few minutes. Since we're, speaking specifically about BLS services, I want to bring up the RSNAT prior authorization process. So repetitive scheduled non-emergent ambulance transports. So the prior authorization process for this is a process for Part B ambulance suppliers that are not facility-based. So that's important to remember. When you have a beneficiary that you're planning to take them on 6 or more one-way trips in a 10-day period, or at least 2 one-way trips per week for at least 3 weeks, you should consider submitting for a prior authorization of these services. So the codes that fall under the prior authorization process are listed here on this slide. We're not going to go over those, but I encourage you to take a look at those. Now, this process is not a condition of payment. However, if you don't submit a request for these repetitive services, the claim may be subject to prepayment medical record review. All right, so if you submit a prior authorization request and we review it and we affirm the decision, so we say, yes, it's okay, to schedule these out and to do these transports. We're going to provide you with a unique tracking number that's going to need to be appended to your claims. That unique tracking number is valid for a 60-day period. If you are going to require more transports after that time, you will need to submit another request for a new 60-day period. And on this slide, I've given you a link to read more. Since we're not focusing on RSNAT services today, I do highly encourage you to go out to our website and read more about this process. But I am going to talk just briefly about some of the documentation. So when it comes to the documentation requirements for RSNAT, these are a little different because it's before the transport happens. I'm going to go out of order of what's on your slide deck, but this is where it's your physician's time to shine. Use that PCS form. Have that physician document everything possible to help support the need for transport by your means, by ambulance. Our sample form, again, was developed to assist you in making sure that you capture all those necessary components to prove medical necessity. So besides the demographic info and the transport destination information, et cetera, it helps us understand what exactly you need to do for your patient during that transport and how those things are going to be accomplished by your crew. So if there's any special handling, any special positioning needs, inability to sit in the chair or the cot, et cetera, those are things that are captured on that. And then also there is a prior authorization request form. Now, a link to this form is available in your slide deck, and this form needs to be completed in its entirety. It includes information on the supplier, on the beneficiary, on the plan, how many transports. Remember, a round trip is considered 2 transports, so you need to document by how many single transports, one way. It also has contact information for your representative, so we can call for any questions or additional documentation needs. So at this time, I want to pull up at least one claim example and kind of run through a claim review with you guys on information that we actually see and review when reviewing ambulance services. So I have sanitized everything out of this documentation that pertains to the patient or the supplier, et cetera. So we have an ambulance transport in this case for BLS services for an 89-year-old female. And their billing charges are listed here for BLS services to the ER, 1.7 miles. This is just kind of their billing sheet. This is their run sheet here. So this gives the information. They were called out ALS 2, but non-emergent, to a residence, a single family home. Destination was a hospital emergency department by the patient's choice. Their loaded mile was 1.7, so that was probably the closest available facility anyways. And then just a little information about, how they were moved to that facility, and it was by stretcher, et cetera. Now, what I'm going to do is scroll down, and we're going to look at the medical need. So when they got there, and let me scroll back up, and it didn't say, and this person had a fall and ankle pain, but we'll get to that down here as well. So medical need was a fall. Unable to get out of bed on their own. It says no, but all of these things say no. So I'm not sure as we go through, some of this will make more sense when I question why this says no. So unable to get out of bed, no. Unable to sit in wheelchair, no. Extremity requires evaluation, no. Required stretcher, no. Restraints to prevent fall, no. Unable to ambulate, no. Everything's a no here. So the chief complaint was foot pain for at least 2 days. We have some assessments of airway, breathing, circulation, all within normal limits. We have neurological assessments, all normal. We have an overall head to toe assessment, which is coming out normal, except for some swelling in a left leg. We got a good Glasgow Coma scale of 15, and then we get down to the narrative. Dispatch non-priority. Patient complains of left foot pain following a fall a couple of days ago. So no acute distress, alert and oriented ×4, no immediate life threats, no obvious injuries. Patient states that the fall happened after their knee gave out a couple of days ago. Since that time, they've been experiencing some left foot pain that radiated to the knee. Didn't lose consciousness, didn't hit her head, no other injuries at this time, no abnormalities or pain. Left foot is slightly swollen. She has a positive pulse motor sensory, denies pain upon palpitation to that affected area all the way up to the knee. Patient actually ambulated to the stretcher from the living room, minimal assist, and a walker, and she sat down. So secured with straps, loaded, transported via BLS per the patient's request. So they got a signature, etc. We have patient signature, we have receiving agent signature, we have technician signature, and if there's credentialing listed, I always leave the credentialing out. In this case, there was no credentialing listed for this. So some interesting things with this example. Let's first talk about the medical necessity. Does it appear that transport by other means were contraindicated? From what I read, what I see, like this patient ambulated, the fall was several days ago, some swelling, no pain, they were able to use a walker, they were able to sit on the cot, they were able to probably go by other means. They probably just didn't have other means, so they called an ambulance, which unfortunately Medicare doesn't cover that. So one thing to consider, this might have been a case where we needed to let the beneficiary know in advance that there's reason to believe that Medicare may not cover this, and you may need to know that you may be responsible for this transport. Another interesting piece was next to these signatures, there was no credentialing. So we only have technician. We don't know what level of technician this is. Is this an EMTB, which is the minimal requirement for a BLS transport. So neither signature contained credentialing of that crew member with a minimum requirement of EMTB. At the time of call out, the services may appear reasonable and necessary because you had an 89-year-old female that complains of fall, foot, knee pain, persistent for 2 days. You don't know. It was probably dispatched, appropriately based on what you saw. However, when the crew arrived and assessed, and she's able to ambulate, and it's per her request to a specific hospital, and her gait was steady, and there was no pain indicated, and the only thing was some slight foot swelling, it's determined at that point that transport by other means was contraindicated. So looking at time, we have one more piece of documentation I'm going to quickly just show you. And this is a good example because I don't always want to tell you bad things. But here's a good example of a physician certification statement. Again, demographic information. When we get down to the medical necessity questionnaire, we have a right hip fracture, unable to tolerate a seated position with leg bending for a period of time. The patient has to have some specific seating positions, a 45-degree position to help relieve the pressure in the hip. Patients non-weight bearing, etc. Whoops, sorry. I did something funky and yeah. Anyways, didn't mean to do that. So we have some deconditioning due to age. The additional documentation that was provided for this patient also helps explain why these positionings are also important, because this patient was just discharged from the hospital. This transport is to a dialysis facility. The person not only had the fracture and inability to do a surgical repair of the fracture based on the patient's medical condition, so which puts them at non-weight bearing, but the patient also had DVTs or deep vein thrombosis or blood clots, not only to the lower extremities, but also to the carotid. So it's important, you know, in this case that we have that additional information, and this helps support the medical necessity of the service. So I know we are running short on time, and I am going to just go to the Q&A, and I'm going to ask Tom, do we have anything we need to cover or any questions that have come in that I need to answer from the chat or pre-submitted?
Hey, Mary Sue, no, I answered everything in the chat that came in. I put a couple of questions out there. So if anyone's looking for anything, put it back in the chat. We'll get that answered after the fact. So you can go ahead and go on.
Perfect. Now, I think Tom and I did a pretty good job of covering all the pre-submitted questions within our presentation. We did get some like, you know, specific requirements for BLS documentation and medical necessity. And I really think that we have covered all of that. So I am, in the interest of time, going to move on. I appreciate those that are able to stick with us for just a few more minutes as we wrap things up today. So on your slide here is information about our survey. Tom also provided a link into the chat. We value your opinion. Not only is this your opportunity to tell us what you liked or didn't like about this actual event, but it's your opportunity to tell us what additional education you would like us to provide in the future. There's more information, again, in the notes section of your slides. So again, please refer to the notes section of the slide deck, because we do include additional information in there. But on behalf of Tom and myself, I want to thank you for your participation in today's event. So this concludes our webinar, and you may now disconnect.